gone
Hey,
all week,
Stein,
so I'll just check
sorry
on
about that.
something.
Hey, Stein, you're live. Okay, thank you.
I don't think that's me.
Well, you have two things on, and one was live. We could tell, but go ahead. Let's see. Fiona, keep going. Okay.
That's about the size of it, Paul.
Yeah.
It's just
Okay,
a rather unhappy place to work at the moment.
Yeah,
From my point of view, working for a charity, we continue to be pretty busy, seeing some really gnarly cases. So I'm happy. Did some really good flying yesterday.
all right.
Good stuff.
If you had some cool lessons learned from your gnarly cases, I'd love to have you present it sometime. Okay, keep that in mind, like just a 5-minute case presentation we can learn from. I was it struck me, we were just having a conversation about AI, and it has to do with information in and out, and you got to look at the patient, and sometimes you can miss things. Like the very nice analogy that was made was the issue of how our EKGs are very smart. You know, they do these things, but then you got people like, hopefully people like Amal around who can say, here's where you can get fooled, you know, that kind of thing by this EKG presentation. And especially the whatever the algorithm tells you is the diagnosis or assessment under those circumstances. So yeah, so we're having similar problems here, Fiona. We've had total cuts in different areas, and it's been very, yeah, and it's eking down to the local levels like you're seeing. So, for example, I was just talking to David Person. His daughter is an epidemiologist at the local health department, and she's going to get her job cut because funding that supports a lot of these things are no longer traveling downhill. So I think we're going to see the health of our nation, you know, going down in a very indirect manner and all that. And a lot of people are also very unhappy, whether it's some small businesses or whatever, or even just the average person, like David said, her people, a lot of people's 401ks are now 201ks, which are the pension funds, you know, that they're using as investments, and they've all crashed in recent years. So it's an unfortunate, you know, the kind of situation. So sounds like it's a worldwide problem, and not just you know, with what's happening here. When did the new health secretary or minister come in? How long ago was that, Fiona?
So he's been in since the Labour government came to power in August last year.
Okay, got it. All right.
But he's just decided to get rid of the NHS, NHSE, the body that oversaw the NHS, and put it all into the Department of Health. So there's a lot of infighting for jobs. It's all a bit unhappy.
Very interesting. Okay. All right. Anybody, before I move on, let me look at the chat. Does anybody else have, see, Seagulls, Peter has an epic job with those webinars and his guest topic. Okay. So listen, does anybody else have to get off in the next little while like Fiona did? Mark, go ahead.
Yeah, well, I got to jump at 9 to another meeting. Nothing terribly earth-shattering from my half of LA. Clayton may have an update on the blood pilot that county's doing, but not much new here.
Okay, good. Let me ask you this. Have you guys all gotten invites to the Eagles meeting? Because apparently we have to get our hotel, or it's gonna the hotel price. We have a really good rate, and it's gonna go away this week or something, or within the week. And so I want to make sure everybody's signed up, because then you would have to pay the, you know, the balance, you know, that kind of thing, right? So anyway, you got the general idea then. I just, if you don't mind, make sure you got it. Is anybody not on the call here, not gotten an invite, as far as you know? Probably most of the people that I'm seeing here should have gotten an invite. Say again, Terry?
Yeah, I haven't gotten anything.
You have not gotten anything? Okay, let me write down your name. Can you spell Terry for me? Okay. I was telling some stories that yesterday to Josh Gaither, and I were talking, and I was telling the story about when you turned to me in the elevator and said you have no boundaries, right? That time years ago. So Terry V, okay, not
Peter,
invited.
I haven't gotten anything either.
Who is that? Is that
Right,
John?
Yeah.
Okay, John. Okay, good. Thanks, John. John, I have to talk to a couple of people. You got my email reply, right? About the time.
Thank you.
Yeah, we're planning. You're getting plugged in. Don't worry. You know, yeah, I just don't know yet when, because it depends on other people, because I don't want it to be redundant. Like, I want to make sure you're in a session that we are running, for example, Wednesday afternoon with First There, First Care, but I can't, I got to get approval from the people there. And so, and then what I'll do is plug you in also with, Eagle Creek, et cetera. We wanted to have that discussion, obviously, correct?
Right.
Clayton, you were going to do a follow-up on, Clayton, you were going to do a follow-up on what Mark just said?
Yeah, and I also have to jump off at 9 Pacific. In fact, I didn't expect to be here. My 8:30 meeting got pushed back to 9, but
Okay.
I'm happy to say that a unit of blood was given in LA County for the first time. I'm a little disappointed to say that it was by Compton Fire Department and not by us, but it was for a patient who was having extreme bleeding out of a colostomy site, and the patient did fantastic. So very, very happy. And we officially announced yesterday with the press conference that our system is live. So yeah, thank you to everyone on the call for the support.
Okay, good. And Eric Banks says, nice with the capitals, all caps. Just want you to know that must be really a good thing. So, all right. And Stein, you were asking me about who's running the hotel blocks. And that's Johanna Cinque. Did you not get an email from her? Johanna Cinque, Cinque.
Yes, I did. If that's coming across as me asking that, then we have to figure that out because I didn't ask that question.
It says Stein Bronski. Let's see here. Stein
I
Bronski,
wonder,
host and panelist.
Oh, it was me. It's Miramontes. I got it.
Oh, okay.
got it. You know what? I
doing that?
wonder, I wonder if it's because I forwarded the invitation to Miramontes and Glenn that it's for some reason coming across as me. We'll figure that out.
Okay, got it. Okie dokie then. All right, let me get back to that then. Okay, Stein, you can lower your hand out, right? Correct. Okay. And so a lot of people have to get up soon. Jim Augustine, you and I, maybe we should quickly go over some things if you have to get off pretty soon. And I'll make sure I got you on, Amal. And how are you doing on time, Don Jenkins?
No problem at all.
Okay, good. All right, so we're gonna probably go to the survey. And the survey, before I do that, we got an invitation to have an Eagles track, so to speak, but it's going to be a pre-con at the American College of Emergency Physicians in Salt Lake. Sort of similar, John Jenkins, by the way, to what we did this past year when we went to where were we? Las Vegas, I think. So, but this is going to be on Saturday. It's going to be a pre-conference thing. And I just wanted to pose a general question to everybody. I think the fact that you guys are on here today probably answers my questions, but what I was going to say was that I was trying to tone it down last year and not say it's an Eagles thing, because I always try to say we're not some special organization. We're just, who we are. We're loyal members of ACEP, NAMSP, et cetera. And not try to think we're anything special. We're just who we are, and we get together and have a good time like we're doing today. But they were very interested. They wanted us to promote the Eagles concept. I talked to Jeff. I talked to Jeff Goodlow. He said he thinks it's a good thing with that organization. I always worry that there are some people that are, wannabes or whatever you want to say, or think that we're trying to be something special when we're just meeting, here, etc. And so, but the organization, meaning, can you guys read this? Okay, by the way. Hey, Jim, can you see this?
Yeah.
Yep.
Yeah. Okay. I gotta go back to see. So I don't know if that runs, is that okay with people? That's what they were suggesting, the ACEP folks. Does anybody have a problem with that? Or is it bad to over promote ourselves? Because I'm trying to make sure we are always, grounded, et cetera, if you know what I mean. So anybody have any opinions about that?
I think it looks cool, and it'll grab people's attention. And I'm very proud of the Eagles, and I feel very proud in ACEP settings, saying that the Eagles contributes a lot to what goes on in emergency medical care.
Okay.
We need the t-shirts too.
What was the other opinion? Heard something. Okay, David Miramontes, you had your hand up. Is it relevant to this or?
Yeah, Paul, I'm sorry. I'm on a phone call with the medics.
You had your hand up. That's why I was. Okay. Okay, so I guess I'm gonna go ahead and proceed since that was their wishes and you guys think it's a good thing. I want to make sure it doesn't backfire or then, it's like there's been people over the years, they go, here they go again, 10 years ago, I know, there were people, just saying we're sort of this loose cannon, but we're just, whatever, I just trying to be sensitive to make sure we're not overplaying ourselves in this thing. But, so it sounds like, anyways, the feedback I've gotten is go ahead and do, and I don't know what the right word is, acquiesce, but go ahead and coordinate with ACEP to say this is an Eagles pre-conference. So, all right. So does that sound, anybody have objections or any other suggestions? And do you like the soaring with the Eagles? Is that okay? All right. Hearing no responses, I'll go ahead and talk to them and tell them that's what we'll do when I get together. Now that also leads, please let me know anybody who is going to the ACEP meeting, because they don't have a lot of funding. I'm trying to keep it cheap so people will come, the registrations. And so since I'm going, I'm just volunteering my time there, etc. So if you're going to as well, I'd like to put you on the panel like we did last year. That was a great meeting last year, by the way. And Don, thank you so much for contributing to that last year. So if you want to come out to Salt Lake City and on September 6th, I think we're going to have the meeting is when it is. I'll tell you exactly what it is. It's a Saturday. And they're talking about Saturday, September 6th, I believe, is a Saturday at that time. I may be wrong, but
That's correct. It's a really early meeting for ACEP. Everybody needs to be aware. It's that the weekend or the Monday before is Labor Day.
okay.
And then and then that meeting is pushed up a little bit. So it's a little surprise, and it's the first time it's ever been in Salt Lake City, Paul.
Yeah, exactly. I've already talked to Peter Talak, and I'll be talking to Scott pretty soon, and he's going to try to publicize it across the state. He wants people to come to our show, so to speak, right? So, and Peter Talak is the, just in case you didn't know that, Peter is the state medical director there. He's been at our meetings in the past, even gotten awards from us. So he's a fantastic guy. And then, of course, Scott. So we'll try to get a lot of people to come and attend this as well. All right, so let's move on. Let's get the survey out of the way since Jim, you have to get off. So who should take the lead on David, or did you assimilate the survey on the credentialing? We got that talk from him last week, and I think you now have more of a numbers on the survey. Yes, who wants to report on that?
Dave.
I could start. Yeah. So what the question was is how long does it take to credential a paramedic after they get out of paramedic school in your system? And the short answer is weeks to many weeks. Some looks like, and the numbers, I didn't really get that because the survey was cooped up. We couldn't get the number of shifts, the number of weeks, generally speaking, in most of the studies. But it looks like it's anywhere from, it could be anywhere from short as 7 or 6 to as many as 40 or months. And the point of this is that we're all over the place on this. And that's okay, because you're tailoring your credentialing to your system and to what you're doing. But I just need a little information to push back on my fire chief that 7 shifts is not enough. And I'm going to tell you, so we have our own paramedic school. So we have 6 months of school, and then they pass the registry, and then they go back to a boot camp for 2 weeks. So we have to unlearn registry land and learn our own operating protocols and how we do things in operations and how our ambulances work and all that kind of stuff. And then we do 7 shifts. Well, it ends up being 10 or 12 by the time we go through the process, and which they're writing with a field training officer. And they're evaluated daily with the Power BI program. And we just go through the process. When we think they're ready, they come see the medical director for an interview, which is a oral board test on protocols and management. And we actually, stress them a little bit to see how they do under stress in the office, to see how they do, basically to emulate what they do in the street. So we have that process, we found, has not been as long as it should be. and they're not getting the experiences that they need to grow as a new paramedic, with the supervisor providing feedback and filling in knowledge gaps. I mean, these guys have not seen folks in a cardiac arrest. Sometimes when they come to my office for an interview, I'm going, nope, right
Yeah.
back out you go, until you see a sick patient. So I think the interview was helpful in that regard, in the survey rather, to show us that we're kind of on the same path as far as the kind of patients we want them to see.
Yeah.
But the length, a lot of that is probably determined by your agency, less so by the medical director.
So yeah, and I think we probably understand the pressures for the chiefs, because they have shortages, they got to get staffing, they don't have to pay overtime for whatever, if that's an issue. At the same time, we have to use the word accountable. We're accountable for their actions. If we put them on the streets, we're accountable. And so as a result, my livelihood is based on my medical license. And if I lose my license, whatever, that's the, I think the big issue, that we do have to stress. I think most of them understand that, but I think then it's up to you to decide whether, and actually a lot of times what I used to do is I would use the other paramedics, like the people that are really well-known and well-respected medics or supervisors in a room. And it was like a jury of your peers. I'll say, would you let this person take care of you? We could go through all these sort of, mishmashes or tests or, whatever. But in the end, we said, would you let the gestalt of, would you like this person take care of your mother tomorrow or your daughter, whatever, was the acid test for me, et cetera, in the end. But that took a while to get to for the reasons you were stating very nicely, so.
Yeah. So in our system, you're seen by many people. So first of all, you're evaluated by a number of people. You're evaluated by your training officer, they're actually paid a little bit extra money to do this too. We train the MTOs to how to evaluate. We use the Power BI or the Agency 360 system to document how they're doing during their fellowship, so to speak. And then one of my civilian paramedics or nurses from my office ride out with them. And they give me a, yep, ready for interview, or not ready for interview, three more shifts, right? Yeah. And then they come to the office and the three of us or the four of us will evaluate them using kind of a scripted scenario process. Now, when that happens, about 50-60% of the time we have to go out for more shifts. So that was the point of this whole discussion: is should we just put it out longer and stop this back and forth stuff that causes consternation and scheduling issues? The other thing that's interesting, that in my belief, is the initial education is the best quality assurance process on the back end. If you train them right the first time, they're not going to make mistakes and have to come into your office. And so getting it right the first time is the big deal. And then as a follow-up to that, we don't allow a new paramedic to work with another new paramedic for 6 to 8 months. So we put them with a seasoned medic. It's been out more than a year for the first 6 months.
So another question is that one of the things I had always done over the years is make sure they're on a busy unit with pretty, sharp people, but they were seeing a lot of cases. So are you doing similar things to make sure that they're out there and getting the time utilized right? It's not a matter of number of shifts, it's a matter of patients they encounter, right?
Yeah, exactly. So we actually had some operational hiccups with our last class. And so midstream, what we did is if they were assigned to a slow vacation station, we'd swap units.
Right.
So the vacation station boys would end up taking their students into the hood, so to speak. And the guys that were running a lot of runs all the time got to go to a vacation station. Now, there's pluses and minuses to that, right? The pluses are, they're going to a slower station, but it's not their station, right?
Yeah.
So, firefighters, what do they hate the most? Change. What do they hate the most? Staying the same. So you can't win the same. You can't win, right?
We've been hearing that a lot recently. Where in our neck of the woods. So, all right. The other thing is that I think it is system dependent. So there's a lot of the systems that I thought have done a great job, and the paramedics have been very sharp. Is that they first had they had a tiered system with basic life support units. So the EMTs were out there and they got experience, so that when it went to paramedic school, it made sense. There was an abstract, the heart attack wasn't an abstract concept. They've been used to seeing it and all that. Just sort of the things that you were saying is upfront training makes a lot of difference, out there. So, okay. And then hopefully,
So,
your folks
so
also
actually,
are you guys doing before you go to that? Are you guys also doing sort of like if you're at the station, do the people, check, train them with EKGs or put cases out in front of them? Okay, go ahead.
actually each assigned shift, they have assigned topics that they have to go through and check them off at, even if they don't run that call. So we're trying to do this very extensively. So interesting, Paul, you talked about folks that were EMTs for a long time. All of my paramedics have been a firefighter EMT for 4, 5, 8, 10 years in our system, and then they promote in EMS, right? So you would think that experience would make them better paramedics.
Yeah.
And to a degree it does, because they can see sick, not sick. But a lot of times actually it's counter, because they're like, I'm on the fire truck, I get vital signs. Okay, go to the ambulance, we're done, right? They don't see the whole call.
Yeah,
So they only see the first part.
Okay, but that's the first responders I'm talking about. I was talking about tiered systems where you're actually doing the whole thing. So that kind of thing. All right. Well, let's move on though. But David, thanks a lot. Hope this was helpful to you. And then I'd be very glad to help out in any way myself personally. So, all right.
Yeah, thanks to the Eagles. This was very helpful for me because we got to see a smattering from big places all over what that's all about. So that's great.
And
Thank
Dave,
you.
I want to make sure you knew there were 35 survey total that we got to. Paul, we figured out we were missing some addresses and all that, and Mark Worth and Stein worked through all of our lists to make sure everybody's getting them. And we ended up with 35 surveys returned, and I'm very happy thanks to the Eagles.
By the way, on the stroke thing, they were very happy because I think we had up to 50 responses on that one. And it's the other same thing, by the way, they were all over the map. Mostly in terms of the people had known about the stroke center, let's say guidelines or whatever, but whether people were using RACE or they were using, various other stroke scales was all over the map, et cetera. So, but it still was interesting for them, and we're going to continue to go on and do some more surveys with them. But it was really great to have that kind of, 35, 50, whatever, fantastic. So that is thanks to you and the group, that kind of thing. So, hey, John Jew, you had a comment to make before I move on. And Ben Weston, be prepared. I'm going to have you make your quick announcement, okay? And then we're going to go to Amal.
Yeah, my only comment, Dave, is really good for that survey, but I think for our system, if you have 2 paramedics and have what we call a junior and senior, that's different than having an independent paramedic here as well. So I think the context of the survey should perhaps be improved, knowing how your system is configured, and every system is completely different. Yeah. So yeah, I think that's my only editorial comment. It's a great survey. Thank you, David.
Okay. I'm just sorry you're having the problem, but I think everybody else is going to have the problem too. It's going to continue to get a little worse with various issues. Roger, can you give me a 30-second bullet? Because I got to move on here.
Yeah, so there's a lot of moving parts in all of this, depending on what your medic is doing. But in a nutshell, what we try to do is treat the credentialing process a little bit like the House of Medicine. You have undergraduate people in our own class that are trying to become medics, and they have an undergraduate preceptorship before they graduate, and then we actually call all processes after graduation and you're NREM TP eligible as an ALS residency, and people do a residency and it culminates in evaluative and then a final residency oral exam called the OSCE, and that's I put that in our survey. And we found that takes care of all of these different moving parts depending on how your medic is being credentialed in your system.
All right, thank you very much. All right, let me move on. We can have further things in the chat. Ben Weston, you just wanted to make an announcement and an outreach for potential opportunity for speakers, right?
Yeah, thanks, Paul. I just want to mention real quick. So I'm chairing the Public Health Committee for NAMSP. One of the things we're going to try to start doing is every other month, having people come and talk about a different public health related EMS topic. And so the first one's going to be anything related to treat and place, any treat and place initiatives that are happening in different EMS systems. It's going to be, I can send out the date, or I'll put it in the chat, but it's going to be May 20th, the next one at 1 p.m. Central. Obviously just a Zoom thing. It's an hour short, 10 to 20 minute, casual type presentations. And it can be you if you have one, or if you have somebody, more junior who would be interested in presenting real quick the work that you guys are doing, that'd be great as well. So just shoot me an email or put a chat in the text or in the.
I was looking to see if Peter was on, because this is exactly a hot issue with him right now, because of Brevard County losing a main hospital right in the middle of the area, and they've had to create or recreate a new treatment release. It was like an update of what happened during COVID. And so that would be, you ought to contact Peter and see if he's available to do it, because he's just hot and heavy into this right now.
Cool.
And,
yeah, I will.
Yeah. And then I'll help you out on various things. So you think we should have just one presentation for about 10, 15 minutes or something like that?
I mean, I'm open if somebody wants to talk the whole time. I was trying to make it kind of low commitment.
I think it's great.
You don't have to, it doesn't have to be, I mean, if you want slides and stuff, but you can just kind of talk about it. I'm sure it's a pretty engaged group. I think people have questions. It's a very, junior group. There's a lot of people who are kind of new to EMS, just finished their fellowships, things like that. So I think they'd be really interested to hear what's happening in different programs.
And my suggestion then would that you do make it short, like maybe a couple 10-minute presentations or something like that with a couple of people, and have an open interaction with them, like we do here. So that
cool. Yeah, I think it'd be great.
That's my suggestion. We'll talk about it later on. I just wanted to get it out there, have people thinking about it, how they could. Are you going to have topics to suggest, or should we try to suggest some topics for you?
Oh, I'd love topics. What we're thinking of doing is themes. So the first one's treat and place, only because we're trying to do a symposium in the summer, I think in August, an online symposium for NAMSP of treat and place initiatives. So this is kind of like a preview of that. But if there's other kind of public health oriented things, certainly any themes or topics would be great.
So it does beg the question: isn't generically isn't what we do public health, or is it public safety and all the above?
That's why it can be pretty much anything.
Yeah, right. That's what I was getting at. And then John Jew said a fantastic idea. Send the link for our fellows to be interested in participating. So
yeah, that'd be cool.
All right, good. Okay, that's enough. I got to get out to Amal.
Cool. Thanks.
Dr. Matu, what do you have for me and you, right? So Amal, you had actually you're just going to report. This whole thing I put out today about positioning ourselves right here. Okay. And so there is some new guidelines that just came out from, I think it was a Heart Association.
I don't know that I would say that they're new. I think rather than an update, it was more of a reminder of a lot of things. Nothing, at least from my standpoint as an emergency physician, I don't think there's anything really groundbreaking. But I had presented this at AAEM recently, and so I just wanted to share a few slides and some questions that came up also. This was, let's see, where are these slides? There we are. So hopefully everyone can see these slides. This was just published April 1st. And I'm going to come back to this. So again, they just reminded everyone that the key thing to focus on is first medical contact to balloon or needle time rather than door to balloon or needle time, which I think is oftentimes forgotten by a lot of emergency physicians. And I'm going to come back to this in just a second, because I'm interested in hearing what everyone else has to say about that.
Remember, what's FMC stand for?
First medical contact.
Okay, got it. Okay, yeah, okay.
So that's where the EMS folks are contacting patients.
Make sure
they reminded everyone about posterior STEMI. It's still probably the most common type of missed STEMI.
Okay, here's an interruption. The first medical contact could that be a call to 911? I mean, just, you see what I'm saying?
I think generally they refer to the medical personnel arriving and touching the patient.
Okay, good.
Posterior STEMI, again, is the most commonly missed type of STEMI because it doesn't show ST elevation on the standard 12 lead. And at least a couple of times a year, I'll see a case or hear about a case of a true posterior STEMI that was sitting in the waiting room because it was listed as no STEMI. And so just a reminder that they sent out again about getting posterior leads anytime there's any ST depression in your right precordial leads, V1, V2, V3. And this is not new. Again, this has been part of the ACC/AHA guidelines for a number of years. This was in the European Society of Cardiology STEMI guidelines way back in 2017 and even preceding. And again, that you only need a 0.5 millimeter of ST elevation on those posterior leads to make your diagnosis. Again, not new. This was republished in 2022, and I think we talked about this document back when this came out. And just a reminder about this is where your leads are supposed to be placed, and you'll just take V4, V5, V6 and put them in, I'll just say the left mid-back area, and look for at least a 0.5 millimeter of elevation in any one of those three. You don't need them in all three, but any one of those three. Here's one of the examples that I showed. This patient was initially missed, and you can see that there was ST depression a little bit in V1, a little bit in V2, a bit more in V3, and your computer's not going to pick this up. Your computer's going to call this maybe subendocardial ischemia, or most people will say maybe anterior ischemia. But anytime there's depression in those anterior septal leads in somebody with cardiopulmonary symptoms, you just do some posterior leads, and you can see that on the posterior leads here, this patient's got at least a 0.5 millimeter. So this was a posterior STEMI. Patient went to the cath after some delay, and this turned out to be 100% OM1 blockage. And this is a paramedic case. This was sent to me by a paramedic in London. And as I understand it, the system that he was working in was one in which they take the patient to the nearest hospital. But if they diagnose a STEMI, they'll drive an extra 15 minutes to the cath center. So it makes a big difference about where you take the patient. And this was the initial 12 lead. You can see that there's ST depression. Your computer is calling this some anterior septal ST abnormality, but it's not calling it a STEMI. But this paramedic did posterior leads, and it's clearly a posterior STEMI. So he drove the extra 15 minutes to the cath center and saved this patient's life. So the posterior leads can make a big difference here. There was another section where I'm just going to briefly talk about these two diagrams. First diagram on the left, I love to remind people, and this document, brand new, again, is reminding people that there is still something known as unstable angina. And I hear people all the time now saying that unstable angina is gone because everybody has a positive troponin. But this is a very nice reminder that you can still have ACS with negative troponins, and so the history still counts. And here's a great example. This is sent to me by a doc down in Florida. This 90-year-old with all of these symptoms and all of these EKG abnormalities, ST depressions, elevation AVR, all of these EKG abnormalities were new. This patient had 2 negative troponins over the course of 6 hours apart. These were not highly sensitive troponins, but again, 2 negative troponins 6 hours apart. I think it makes a nice case for the fact that you cannot completely rely on troponins. And they also publish this reminder that the troponins need to be appropriately spaced, even highly sensitive troponins. And we see a lot of protocols now looking at checking a troponin 1 hour after symptoms begin. And oftentimes that's just not long enough. Here's a case that was sent to me where you've got a massive anterior STEMI, and this patient had negative troponins at least 2 hours after the onset of symptoms. So again, the history and the EKG still matter. It's not just if the troponin is negative, I don't have to worry anymore. And this document makes a nice case for that. They remind everyone that serial EKGs are really important. 11% in national databases, and I've seen numbers as high as 20%. So we'll say 11 to 20% of STEMIs are not diagnosed on that first EKG. They're diagnosed on a repeat EKG. So if the patient has concerning symptoms, you've got to get a repeat EKG if the first one's non-diagnostic. And I think that's a really important reminder that the repeat EKG can make a big difference. They talked about cardiac arrest, and this is not new also. Once again, they remind everyone that if a patient has post-arrest ROSC and the EKG shows evidence of a STEMI, the default is go to the cath lab. But then there at the bottom, another reminder that if the patient has post-arrest ROSC and it doesn't show STEMI, then those patients are probably best managed in the ED and ICU with good resuscitation, and then they can be reevaluated for cath late a day or two later. So post-arrest STEMI, go to cath. Post-arrest non-STEMI, no cath, but focus on good resuscitation. And there's some there's a little bit of gray area there, but I think that's the default. And for a while after 2015, a paper came out in JACC suggesting that everybody post-arrest ought to be going for cath. There was a lot of confusion. And so the most recent data has really shown post-arrest, no STEMI, probably best no cath until after they've been resuscitated and reevaluated a day or two later. And this last diagram, I'll focus your attention on the box at the far left. And again, you'll notice that this entire diagram focuses on non-ST elevation ACS. And it's just a reminder that there are some patients without ST elevation that nevertheless still need to go for cath within 2 hours. So emergent cath is still necessary. And they're highly recommending that patients with cardiogenic shock, even in the absence of ST elevation, should be going for cath. If the patient is decompensating in front of you, even without ST elevation, they're developing new mitral regurg or new heart failure, that patient needs to go for cath. If they're developing new pulmonary edema, despite absence of ST elevation, that patient needs to go for cath. And also refractory angina. And this is where I see most ACS lawsuits now for refractory angina, where a patient will have ongoing concerning cardiac ischemia and ST depression. And because we've been trained so much to think that ST elevation goes for cath, but if there's no ST elevation, they don't go for cath, people have this mental block and say, well, there's no ST elevation, I'm not going to send them for cath. And that hasn't been true for 20 years now. In the guidelines for at least 15, maybe 20 years, the guidelines have said if somebody has a concerning story and a concerning EKG, even in the absence of ST elevation, they still need to go for cath within 2 hours. And that's a class 1A intervention. And I've seen at least a half dozen lawsuits against emergency physicians who sat on patients who had concerning symptoms and ST depression EKGs, and eventually the patient decompensated after 3, 4, 5, 6 hours. And the lawsuit, the plaintiff attorney just throws these guidelines down in front of the defending emergency physician and says, doctor, didn't you know that this is a class 1A intervention? Right? ACC, AHA guidelines is kind of tough to argue there. And then the last thing, which I don't think I'd seen this before, but this is a class 2B. So the evidence is not great, but they're recommending that if a patient has ACS and they're anemic, shoot for a hemoglobin of at least 10. And based on the GI literature, all of our residents think about 7. But for ACS patients, we should probably be shooting for 10. Again, not based on perfect evidence.
One caveat there then would be that the renal failure patient that's chronically anemic, that kind of thing. And would that be a good or bad thing to do under those circumstances?
Yeah, no, that's a great caveat. That's a great caveat. So it's definitely worth taking a look at their baseline. I want to go back to this at the start. You know, I mentioned that I presented this stuff to at a couple of conferences recently, and I had at least a half dozen people come up to me afterwards and make the point that they work in systems where patients will get brought in and their transport time is more than 2 hours, but their cardiologist will not allow them to give thrombolytics, even though the guidelines really are pretty particular in saying, if you can get this patient to the cath lab within 2 hours, then ship them out. But if you can't get them to the cath lab within a couple of hours, you probably should be using lytics. And these folks are very frustrated because they'll have 2.5 hour transport times out in rural areas, and they're not allowed to give lytics to these patients. And you know, I just feel like if those patients decompensate, people are going to throw the standard of care back at them and say, well, the standard of care is you probably should have given lytics to those patients. And I hear this every time I talk about this. And I'm interested in what your all thoughts are, and I know Dr. Bomber is there as well. But I mean, what kind of things are you all hearing? Are you seeing people that also are in the same quandary where their cardiologists are saying, I don't care that it's 2.5 hours to get them to my lab. Do not give them lytics. And their hands are tied.
My answer to that always is, if this was your family member, what would you do, right? So, but Bill, want to respond to that then? Because you must
Yeah,
have.
I think that certainly for individuals who are not going to be emergently within 90 minutes in a PCI lab, then consideration for lytics should be there. We have a few remote areas in California where they are up in the mountains, and there is literally, we have to get them to a plane. They have to fly to either Reno or some airport. And so we can't actually get the 90-minute delivery. But we have 127 hospitals in California that are PCI capable, and our EMS are instructed to take them in any consideration of an MI, suspicion of MI, to one of those hospitals. And literally in the valleys and coastal areas of California, we can deliver them usually in 30 minutes or so to a hospital. We make the 90 minutes. The only problem we have with longer remotes are the far eastern areas of California in the mountains up in Bishop, where we don't have PCI capable, and we have to literally get them to a plane or helicopter and fly to Reno or something like that. In those cases, we typically recommend thrombolytics on their transport, and then it's up to the interventionalists. They usually proceed, if it's within 2 hours, they proceed with PCI, even in the setting of thrombolytics.
Okay, thanks, Dan. And then one last question, since we should move on, back to you, Amal and Bill, is there any situation in which we should not give aspirin to the folks?
I would say if you've run out, or if the patient has a true anaphylaxis, but if they develop itching or they have a history of GI bleed, you just give them a PPI, then give them the aspirin. If they develop itching, give them Benadryl aspirin. Aspirin for family arrives, give the family aspirin, give the nurse aspirin. Everybody give aspirin.
Okay, good. That helps me feel better, because I'm always carrying aspirin around everywhere, whether I'm on an airplane, at a festival, or whatever it might be. Good. Thanks for that response. All right. So anybody else have any questions or comments for Amal? As usual, it was a nice review. It really was a good one, and especially the caveats and so on. And just and a good reminder, even if we knew all this before. So thank you. I appreciate it. Hopefully you got anything for us next week, you think? Okay. If not, Jim Augustine, you have a hand raised.
Yeah, when is this going to be distributed to cardiology? Because this is, many of our points are nice to have on the emergency medicine side, but cardiology needs to hear and see these also.
It's been published.
Mm-hmm. Yeah, it's not new. It's interesting that there's literature from multiple specialties that talk about the delay from guidelines publication until implementation out in the real world, and this is just another example. So it's not limited to cardiology. I've heard this from infectious disease and emergency medicine, and everyone is. And I think webinars like this and conferences is really important to get this information out.
Yeah. All right. Hey, while I'm thinking about it, are you going to be able to come out again to ASAP? Could you come be there that Saturday by any chance, Amal?
I'll definitely be at ASAP. I don't know what date I'm going, but I'll definitely take a look. So
let me know.
Exciting that you guys have the Eagles.
Same with you, Jim Augustine. Same for you. Jim, will you be out there? And can you attend that Saturday meeting?
Yes.
Okay, so Augustine. Okay, good. and I'll try to find you an equally cool, Italian restaurant right there. That was such a great night. And thanks, Linda, again. So it was just, you guys are so generous. I love it. All right, so let's then, quick question though, Joe Holly, before you, because usually you have to leave by now for other meetings as the state medical director, and anything to report out of your realm in Memphis?
Hi, Paul. Hi, everybody. No, nothing major to report from my end, and I do have to jump in about 5 minutes, so thank you.
That's why I caught you. Hey, can you do me a favor and resend those contacts that you sent me? I don't know where I did with it, because I want to do follow through and see you in Memphis in a little while, hopefully this summer. Okay.
Sounds great. I'll send them. Thanks.
Thanks a lot. All right. I think it's, unless anybody else have to bolt and want to just make a comment or need to plug in, or else I'm going to go over to Don Jenkins. Okay. If not, hearing no objections, let's go on to my dear friend.
Jim had a question.
Oh yeah. Who is that? Jim Augustine?
I just was going to say a lot of our fire friends are very concerned still about the closure of the National Fire Academy, and all of our data sources are compromised now, including the implementation of NERIS. So Paul, I was going to let all of these people know our NHTSA office may be compromised, our Fire Academy and U.S. Fire Administration are compromised, and the CDC is compromised. So data is going to be a little late in coming out. Thank you.
Yeah, and we won't know about things that are happening yet. So it's just whatever. Thank you for plugging in. There is a question before I go to Don. Says Mick was asking, is that cohort not getting lytics? Are the cardiologists doing PCI at 150, 200 or more? Okay. Do you know the answer to that, Bill or Amal, if you haven't gone?
I'll turf that to Bill.
Yeah. Okay, Bill, any
Yeah, I have no reason why they shouldn't get lytics, and so I wouldn't recommend it. And I would assume the interventionalist at the time has decided it's too late to intervene, and there is a question of whether it's a trans or a ST elevation MI or not. And they're going to other therapies, medical therapy. But for acute MI, we've known for years that going to the cath lab for primary PCI is the best therapy.
Yeah. All right. Thank you so much. All right, let's move on. And Don, so what I understand is you're going to make some sanguine remarks for us, right? So there's a new AABB position statement. First, let them know what AABB is. Just make sure we have a level playing field here, and why this is important or how it affects us.
Yeah, so the AABB is the Association for the Advancement of Blood and Biotherapies. I think they were formerly known as the American Association of Blood Bankers, or at least colloquially known as that. And it's an additional, I'm going to call it a regulatory authority over blood banking and bio therapies, tissues, sera, etc. And they don't answer to the FDA, but anything that they put out is, let's say, just subservient to whatever the FDA says is what holds. They don't say anything that would be in contradiction to the FDA, but they do add in additional layers. And most blood banks are accredited by the AABB. So an accrediting authority, and in that they have an entire association of people that do this, an accreditation process, and it's a very highly regulated. It's probably the most highly, right? The lab, it has so many. The blood bank and the lab in any hospital is the most regulated area in any part of medicine. And so they have so many masters that they have to answer to. And AABB being one of those. And so there was a lot of consternation out in the bigger, broader world from blood bankers. Could they just dole out blood to pre-hospital agencies? And what would the AABB think of that? There was a bit of a shift when we started to allow transfusions to occur outside of a hospital, in clinics and infusion centers, and now even in some situations in the hospital at home, kind of concept. And so the AABB came up with some guidance for out of hospital transfusion to make sure it's all about quality and safety. Right? They don't want anyone to get harmed, and they want to make sure that the blood supply is safe, that blood products are handled safely, and this stems from transfusion transmissible disease experiences back in the 80s, earlier than that with hepatitis, then HIV/AIDS. So there's a lot of quality and safety surrounding this. When this came to the fore, they decided that better to provide some degree of guidance for pre-hospital transfusion than to ignore it, because they realized that this was happening. And they invited several of us familiar to the Eagles, Eric Bank, Randy Schaefer, and I. Eric, was there anybody else that frequents Eagles that was associated? I don't recall.
Not off the top of my head. There's Jeff Siegler, but
John Kramer, was he there?
No. So we were I don't know, selected, chosen, asked to provide some input into that. We sat down and sort of almost unfortunately, the way that AABB thinks of things is this is another transfusion not given in a hospital, and so we fit categorically into their niche, their niche of out of hospital transfusion, when actually it has nothing to do with that whatsoever, right? The out of hospital transfusion group are well differentiated patients with known diagnoses. There's nothing emergent about what they do in that setting, because if there was, they would be in the hospital. And so from a change in thought process, we don't really fit as a pre-hospital transfusion guidance in with the out of hospital, but they didn't know how else to categorize this. Ideally, there would be a break between the two, because when you read through the guidance, you have to parse out what do they mean, which one is the out of hospital sort of clinic setting, and what do they actually mean when it comes down to emergency transfusion and EMS. And so you have to read through that guidance carefully to make sure that you're on the pre-hospital guidance aspects of things. Really, the implication to the EMS agencies that are in that guidance, that if you want to be in good standing with the AABB, then you're going to follow the guidelines. You're going to keep the blood in temperature. You're going to have processes that assure that the blood is safe and is being administered safely by trained people, and that you have quality programs in place, that you check your equipment and you check the training of those individuals. And the key features of this that keep everyone in good graces is that every emergency transfusion administered in this country, they're supposed to be accompanied by a physician's signature. And that's an FDA rule and regulation. And so that if your medical director of your EMS agency or their designee needs to have a signatory on these emergency transfusions, and that's an FDA rule and regulation. The other aspects of this is that they want programs to have performance improvement programs where they keep records of incidents that occur that are untoward, and that they deal with those. They do require maintaining any medical record that pertains to emergency transfusion on file in your organization for at least 10 years. And Eric, again, you can correct me if I'm wrong about that. And that your criteria should be reviewed regularly. You need to have indications that you have reviewed for those transfusions. And there are some peculiar things that happen. A donor whose blood is tested tests negative for any known disease that is tested for, you administer a transfusion from that donor to a recipient. That donor shows up in 2 months or 3 months to donate again, and now they have evidence of a disease that is transfusion transmissible that they test for. Now you get a call or notification from your blood provider that says, hey, you got to find that recipient and notify them that donor might have been in a window where they were transmissible but not diagnosable. And that individual who got that blood product needs to be retested. They at least need to be notified that the potential exists. And so that's an unusual feature of this. That, again, nothing unusual about that in the hospital world of things. It would just be a bit different. And that's a thing that in our hands here in San Antonio and in what we teach people when they ask us about this, is that should be something that's written into a contract between the EMS provider and the blood producer that they contract with, that in some way, shape, or form, the two of you work together on those things. It's probably the needle stick is one of those kind of things that EMS would find itself involved in with a patient and a hospital, and and how do you deal with that outside of the emergent care that you're providing. Eric, any other things that you would?
So the kind of interesting part, Dr. Jenkins and et al. Is Randy and I actually had edits on this. We sent them to Chris. Dr. Pepe asked me to do a presentation. The guidelines didn't come out on the 1st. We thought they were going to come out like another 6 weeks down the road, and I guess they kind of pushed the edits to the side, and they hit print, and the documents came out. So there's still a little, just like some of the things Dr. Jenkins was talking about. There's still a little bit of a misunderstanding of the non-laboratory environment of EMS. We'll get there. This was a great learning experience for everybody that was involved. The blood collector, blood banker, transfusion physicians that participated in this got an amazing education from those of us that participated on the EMS pre-hospital and trauma side. And it was a great, it's translated into leaps and bounds across the AABB. Well, I kind of, for those of you that are familiar with NFPA, I kind of consider AABB like NFPA. You're not required to participate or buy the guidelines, but if you get sued, guess what they're going to go to the first time they go to court is they're going to look for that NFPA guideline or NFPA regulation. I think that it's very paperwork intensive. So I think even those of us who have been doing this for a long time, including, Dr. Miramontes and the group out in San Antonio, every time we go back and look at these, there's a piece of paper we don't have. And I think the first time that we actually do one of the accreditations, we're going to realize there's a piece of paper or a guideline or a process we don't have, and we'll be able to catch it up and then tell everybody else what it is. My understanding is that the first accreditation is going to be a test run. I know the guy that they might be test running on, and we'll see how it goes, and I'll be able to report back how brutal or non-brutal or what piece of paper I was missing. So it'll be an interesting process.
Okay, Randy, are you on with us? I didn't see if you were on.
She was
Okay.
on earlier. I didn't see her.
I didn't see her when I checked.
And I can tell you that Dr. Jenkins took the FDA to task every time we asked an FDA question. Dr. Jenkins ran up the flagpole there at FDA to get an answer. So
Yeah. Okay, got it. All right. Well, anybody, John, anything else you could contribute to this or want to comment on? John Kramer.
No, I just think we all owe a very large debt of gratitude to Don and Eric and Randy and Jeff Siegler. I mean, they were very instrumental in making this applicable and relevant.
Right. Okay, good. And then Don, we talked about you coming in hopefully on Monday in June, right? And be there with us the next few days.
Yeah.
You can make that work. Okay. So, and let me know if you want to come out to Salt Lake City again. It'd be great to have you out there with that same meeting. All right. So anybody else have any questions for them or any thoughts or advice or anything you want that we left out? Is this something you can send out to us, maybe put in the chat or something like that? Eric, do you have that document?
Yeah, Eric, there's a link, right?
yeah, I think there's a link. And it didn't come as I'm winking with both eyes on the camera. This didn't come from us. It fell off the truck.
Oh, I see. I get it.
Yeah, it fell off the truck. That
All
was
right.
the famous saying in South Philly. It fell off the truck. I didn't see if Crawford was on here, but
That's right. Yeah. So I got that reminds me of this thing years ago. This is a total digression here. David Letterman, he had a little shtick where he had a thing where he said, we at the Letterman show are often accused of having very eclectic jokes that go over people's heads. And he goes, so we've set up a new system, and shows a guy in the audience, an older guy, and he's got the earphones on. He goes, anytime you don't understand the joke, we'll explain it to you. And you press the button, and the guy goes, oh, I get it. Right like that. So thank you for getting it to us. Okay. All right. Well, listen, so that's good. Thanks for the report. I guess we'll just quickly go around the room unless there's something else. Mick, tell us about the thing that happened in Toulouse. It sounds like an interesting thing, if you don't mind.
So the European Rugby Cup quarterfinals on, and they decided to do some pre-game entertainment. And they had the military parachute team come into the stadium and fly in sequentially, one of them carrying the ball and the other guys just for show. And the guy that was in the rear got caught by the wind, ended up stuck on top of one of the pieces of the top stand, and ended up getting wrapped around it in the parachute and dangling over the crowd. So they had to clear out all the spectators under that section of the crowd. Our post, because guys are running at speed, the posts have like 1.5 foot of padding around them. They took the padding off all the posts, put it over the seats in the stand. They got a bouncy castle from outside, brought it in very quickly, blew it up and put it up underneath them in case he fell down. And eventually they had firefighters in with a telescope unit to get up to him, to actually get him down safely as he was just dangling from the stand. So one of those very strange, you'd have to see it to believe it, events at a sporting event.
Was it, and with the wind, was he still swinging back and forth and all that, or just hanging?
He was swirling in the stand.
Oh my God, that must have been terrifying. All right. All right, well, thanks for the report. Well, I got John, anything to report out of Ireland or any of the European continents, since I think you're the only one remaining on from that continent.
We had 2 weather warnings in the last 2 days. Yesterday for snow, 18th of April or 17th of April, and we had roads closed because of snow. And today because of rain. So we've 14 of 32 counties under a rain warning and flooding. So it's weird weather for this time of year.
How often do you ever get snow? Because it's like Seattle, we used to not get snow that much. I mean, once every 7 years, and then it started becoming more and more common. Are you seeing more commonly, or what's the story?
No, it used to be every 10 years or so you get stuff that would sit on the ground, but you might get a foot of snow that time, and that would last for a week, and it's all slush and mess. We don't really get snow. I mean, it technically gets cold enough, but it never sticks on the ground because it's not very cold on the ground. But this is very unusual that the roads in the Dublin Mountains of snow for that day yesterday.
Okay, got it. All righty. Well, thanks a lot. And then I think my friend is coming over there tomorrow. You guys have been in contact, right?
I'll make sure to meet her and have a good chat.
She's fantastic. So, all right. So let's then move on. Joelle, we hadn't heard from for a little while. You've been busy, so might as well pick on you first, okay, out of San Diego. If that's okay, Mom.
Yeah, my headphones are dead, so I don't know if you can hear me well enough through
Yes.
this. We are, I think we're pretty steady status quo, just trying to keep up with everything and prepping for education, protocol updates and whatnot. I think an interesting topic that one of our training advisors came up with is there is a new certification that your city can get if you take it's for autism and to be an autistic friendly city. And if 80% of your EMS, like of your city employees go through this, you get a certificate for being autism friendly. So we recently looked at it. We were considering it. We had a pilot of going through it and trying it out. But I think the movement to being conscientiously aware of how we interact with and respond to people who may have differences in how they act, whether it's that they're more of like a low functioning autism or that they have developmental disease or dementia, and conscientiously making sure that everyone in your ranks is getting consistently updated on it is really important. And so we're kind of looking at that right now.
Yeah, tell us what you find and give us an evaluation of it.
Yeah. We I think we're going to try to supplement it and augment things with we have some autistic centers and like autism specialists with our children's hospital and locally. But the other group that I think might really benefit from it, especially having a shiny certification, is PD. Because I think there have been a few shootings of people with like learning disabilities and like communication difficulties lately in the press.
And not just in your part of the world, like actually less often in your part of the world, but more commonly elsewhere. So that's great thing. Yeah, it's a good point. Yeah.
Yeah, so important consideration. And I think we're just teeing up, getting ready for lifeguard season, increased populations for tourism and putting one foot ahead of the other. It's a border town, so we're staying busy.
That's right. Okay, good. It's great to hear from you. And thanks again for helping us out with Dr. Ramos's group. And I think she is actually coming to Eagles. I got the word that she may come at least for Thursday. So that would be kind of fun. So you guys can regroup.
Did you email out to all the Eagles? There's the new ACOG recommendations for EMS that have been officially released.
Thought we set those up, but I'm not sure. Jim, are you still? Jim might be off, I think. Do me a favor and then send those guidelines out to Jib and see if we can distribute it to everybody. Okay.
Sounds good. Thanks, guys.
Thanks a lot for doing that for me. Just a quick repeat. Today's what's the word? CME number again is 21370. 21370. And for those who were on the Siegel's call, that was 21369. 21369. All right, let's move on. So great to hear from Joelle. So thank you so much, my friend. Let's see if let's run up to the trying to think where I should go next. I'm just trying to pick on. Well, Ben, how about you? Anything you could tell us out of Milwaukee?
Nothing new, I don't think.
Okay, got it. Thanks for starting up that program you were talking about. Okay.
Yeah, of course.
Dave Obert, anything up in the BC area or Vancouver or Victoria, anywhere in your neck of the woods?
In my neck of the woods, it's absolutely spectacular weather. So that's been a welcome change from the dreary, overcast and rainy winter. Spring is finally here. Otherwise, I can't remember whether it was last week or 2 weeks ago, but when Mike Feldman presented to the Eagles, it's just another shining example of what the Eagles group can do. But he and I touched base offline and started comparing notes about how we were looking at our dispatch systems between Ontario and British Columbia.
Yeah.
That we've sort of independently come to some very similar conclusions, and I think there's a really good opportunity for collaboration ahead. So again, thank you to you and everyone on the Eagles for having that. That's what makes this group so special.
Oh, that's great to hear. That's very rewarding. Well, we'll need to do afternoon tea at the Empress sometime. Okay, I'll try to figure out my way up there.
Perfect.
All right, David. Good. Thanks again. Dave, are you going to be able to come this year?
I will decide the next day or two. That the challenge is, I think I mentioned, I have a newborn third child, so it's a question of whether we're outnumbered at this point. So if we can get some grandparent coverage to come in, then I might be able to sneak away.
And take your bride along if you can. And even if you could come for a couple of days, I think if you could at least make it to the Eagle Creek meeting, we all think that's the best part of it all. It's like this on steroids, that kind of thing, right?
Yeah,
you're right.
Exactly. I'll try my best.
All right, good. Hey, Dustin, anything in Cincinnati?
Well, we're well behind everybody else as usual. But interestingly, with some of the stuff Dr. Ju was talking, or Dr. Matu was talking about, really resonates with me. I have a really small fire department here that I almost never talk about. They're, AEMT based half the time, who had a great run the other day where the patient was, it was a car accident, but did something, spidey senses went up. They thought, hey, this doesn't seem traumatic. They did a 12 lead. The 12 lead wasn't super convincing at first, but something about it they didn't like. 5 minutes later, they repeated it, and it was a STEMI. They take this to the hospital, and sure enough, they called him ahead, did everything. 21-minute transport. Hospital had done nothing when they got there. Took them 10 more minutes to activate the cath lab once they got there. So now I'm in a fight with this hospital about its 1990s practices of disregarding our activation. So that's sort of the where we are with doing things in Cincinnati. But we're making slow progress on that, putting out some chase vehicles with Cincinnati Fire. So making progress, trying to catch up with the rest of you.
All right, it's great to see you. Then how about you? Hopefully you'll be there as well, right? So
yes, absolutely.
You got to help me with the coins again, right?
Yes, sir.
All right, Mark. Hey, you had your hand up. What up? And
yeah, I just I have an unfortunate update today. Yesterday, one of our fire captains, not a paramedic, was arrested after we discovered a narcotic diversion issue that has become quite large. We have found nearly 200 adulterated vials of morphine and midazolam deployed on half of our stations, probably going on for about 2 years.
So could have been harmed to patients, or at least they didn't get what they should be getting, right?
We're going to be reaching out to probably 300 to 400 patients.
Yeah. So tell me a little bit more about that. So when you said it was diverted, so was it both the midazolam and the, what was it, morphine you said?
Yeah.
And
so the way
they-
we discovered it was that our
Yeah, go
controlled
ahead.
substances are stored in a plastic box with a clear cover and secured with one of those breakaway numbered tabs, so that as long as that breakaway lock is intact, then we are assured that the medications themselves have not been accessed. When we receive a shipment of medications, each vial is assigned a unique identifier number, and that and a label is printed in the fire department. That label with the lot number and the unique vial identifier and a barcode is placed on each vial individually. And then we have a computer system that tells us when each vial is scheduled for expiration. What happened was one of the vials came up as expiring later on this month, and per routine, one of the 3 people at headquarters who's authorized to access central supply brought a fresh supply out with the paramedic on duty to our engine 30 and said, okay, vial number MS2966, scheduled for expiration April 28th. And the paramedic said, actually, it says here, November of 2027. And then they noticed that the lot number on the label did not match that on the manufacturer's label. We inspected the vial and noted that the aluminum cap had been pried away so that they didn't have to remove the plastic tab. that covers the rubber stopper, the morphine had been removed, and then that aluminum cap was put back into place. And unless you invert the vial, it can be difficult to see. Once you invert the vial and know what you're looking for, the difference between an intact vial and a tampered vial is pretty obvious.
Well,
We
let me ask
discovered.
you, did he replace it with?
We don't know. It's in the crime lab. We don't know what he replaced it with. That the vials are filled with a clear fluid.
Hopefully it was saline, not water.
Well, that's what that's what, and not just tap water.
Right.
Wow. So what we found out from our investigation was that these small plastic boxes that are secured within the main drug box, which are in a locked cabinet, the hinge pin that holds the two halves of the box together is not difficult to remove. So that's how he gained access, by pushing that pin that held the hinge together and then replacing it without breaking that tab. So the past week has been 14-hour days of meetings with the police department and the DA's office and the county EMS agency and the DEA, although the DEA was the least troublesome of all of them.
That's a surprise.
Yeah. It's all about building relationships. We have a good relationship with our local DEA agents, so we're on a first name basis. But
because it's a federal crime in a sense, is DA has his own agents, or did the FBI come into this at all?
so far, it's been the San Jose Police Department.
Okay, that makes sense. Yeah. Okay.
But what's interesting is that he posted bail quickly, so he's out and about. This involves 16 stations because, as many of you may know, it's not terribly difficult to gain access to any fire station. I have all the door codes myself.
Oh yeah.
To access fire stations, so they're pretty widely known because firefighters, may work overtime at different stations, and so in retrospect, he'd been seen in a number of stations and had said, "Oh, I just stopped to use the restroom or something to that effect." So in retrospect, people were puzzled by his behavior.
Yeah. So was he
rose to the
a
level.
popular person or an odd person or any other red flags?
I know him. I've met him a couple times. He's a friendly guy. He didn't trigger any alarms in me. Haven't spent a lot of time with him.
Yeah. Okay.
But apparently, and I don't want to talk about too much that's not out in the public realm right now. But there's background on this.
Okay, got it. Yeah, and that's probably inappropriate for us to ask about it because you have to investigate it, etc. But what a shame, and it's a good. We've had this happen in a lot of the places where I've worked or people I knew, etc. And it actually was a problem for one of our medical directors years ago. Because they held him accountable for not keeping track of this. Because is there a DEA number associated with your name under this?
Oh yeah.
Okay, got it.
Yeah.
All right, we'll watch out for you. Try to protect.
It's one of the reasons, by the way, you should never have your main practice DEA number be the same DEA number you use to for your agency meds.
You're right. Okay, good. Good friendly reminder and awful situation for you, Mark. Good luck.
Yeah, I'll keep you updated as I get more action.
But congratulations on your bride coming home, by the way.
Yeah, that is exciting news. So I'm looking forward to that.
Ben, you had your hand up.
I just had a question for Mark. I don't know if you can't give this detail, that's fine. But you said you caught it by a lot number mismatch.
Yeah.
So if he was just prying it open, taking a little out and putting it back, why did the lot numbers, how did that come about?
Because he accessed all of the vials in that box and then just screwed up.
Okay.
When replacing the caps.
Okay. So if he hadn't done that, it still probably would have been not noticed.
Quite possibly.
Eventually, but.
Quite possibly.
Wow.
All right.
It's been going on for, we estimate, 2 years.
Wow. Amazing. So that's going to be a lot of work, my friend.
I know. It's a nightmare.
All right, let's jump over to a place that has a nightmare every night. Glen Asada.
Yes, as the #1 drug dealer per DA in New York City, I feel for you. We've had diversions as well, but definitely not to that extent as far as we know.
Yeah.
And now that my son is a DEA agent, what I was afraid of is he says to me, "Dad, I don't have a problem arresting you if I need to." I said, "That's what I'm afraid of, but do me a favor, give me at least a 15-minute heads up so I can get the hell out of here." So
you have a what do you call it? Go bag?
yeah, I definitely do. So I think I mentioned this before, but our commissioner has announced publicly that he does not want to be known as the fire commissioner anymore.
Okay.
Instead, he wants to be known as the FDNY commissioner to try to have this inclusion of EMS, which I thought was very interesting.
Yeah.
It's always been
That
the
was
police
that's the
commissioner, the
intent.
fire commissioner. Right.
That's the intent to say we're not fire, we're fire EMS and rescue and whatever, right? Okay, good.
Correct. So that's interesting. For the last 5 weeks, I've been very, very busy in that 5 weeks ago, operationally, we changed the 10-minute rule that we had, which was if you were a stable, low index patient, you could go 10 minutes beyond the closest hospital. So the commissioner asked, as most of our crews, why do patients have a choice? Aren't we an emergency service? And so he initially wanted to just have the closest, but we had to explain that that's not going to work as well. And, many of when I do CMEs, our paramedics, EMTs are like, "Doc, they just need a cab ride." And oftentimes I'll tell them, "You're right. A lot of the calls, they don't need paramedics, they don't need EMTs, they need a cab." So we changed the system now for low index stable patients that they now are supposed to only be able to go to one of 2 to 3 hospitals within 10 minutes. Some areas it's very difficult because only one will come up and we're trying to work that out. But what was happening was a transport decision request. There were 750 to 800 per week to our online medical control. So 40,000 such calls a year just for a transport request. So by changing this, it has gone down now to about 500 to 550. So a significant drop. But now our QA piece is, are we getting more RMA requests? So I've had to tell our people to change the language. We're telling people,
tell them again. I mean, I know, but tell everybody, what's an RMA mean?
A refusal of medical assistance, but really it's a refusal of transport.
Yeah.
So I'm trying to change our culture too, to tell patients when I'm in online medical control, I'll tell patients, "Mr. Smith, please understand that we're not denying you transport to a New York State certified 911 receiving emergency department. You are declining to go to one of these 3 or so hospitals. So you're declining that. And we want to change that language because we're happy to take you there." But the days of, my cardiologist is at Cornell, but I'm in Brooklyn and I want to go there for my stub toe, that's going to be a no. We can't do that anymore. So the Greater New York Hospital Association has been all over me saying that we're not allowing this continuity of care by doing this. I said, listen, every emergency department has a board certified doctor that can take care of the most stable patients as well as the most critical patients. But we do still allow for your post-op, you live across hospital A, your wound opened up, but you had surgery at hospital B. Even though you're stable, it makes sense to go back to hospital B. Can A handle that patient? Absolutely. But even if they're admitted, the surgical staff will be like, why the hell is he here? Why didn't he go back there? So that goes through online medical control, and the physician has the authority to make that medically necessary case. The Greater New York Hospital Associations that cover the private hospitals are like, well, we want continuity of care. I often get things that like, oh, I want to go to New York Presby on the west side of Manhattan because I want Dr. Oz to see me. I laugh because I'm like, he's first of all not there. He's a pediatric cardiologist. He's not going to see you for your stub toe. So those days are done, but we're getting a lot of pushback. And I have to remind the hospitals that medical necessity does not necessarily equate continuity of care. It just does not.
Right. I think so I've always agreed with, the continuity of care if someone is having chest pain syndrome and their cardiologist is there, and I have to weigh that. Are they safe on the way down, and is it going to delay their care? But I think that's important. But what you're saying, like you said, if they had something that's really minor that anybody can handle, just totally appropriate. So, yeah. Well, if we can support you in any way, let us know.
Thank you.
Okay.
It's supposed to be at the low end, but of course, everyone's telling me, oh, there was this bad case, there was that, this and that. I said, listen, they sound horrible. Please give me the date and the call number, and I can investigate it. I've gotten 7 cases so far, and only 1 potentially because of this policy may have been affected. That's it.
And I personally know you're amenable to the issue about the continuity of care issue, but based on some of the people we've talked about in the past, right? And so,
Yes.
so I know you're not closed-minded about this. You're just doing
No,
the
we
right.
are not. We
Yeah.
are not.
Okay, cool. All right, let's move on down to Jacob is the next person I see on the list. How's things in Denver, Jacob?
Going well. Snowing today. So for April 18th, we were in the 70s earlier in the week, and we've got a couple inches of snow here.
And you only get snow like what, once every 10 years, is that right?
Yeah, this is a little bit of a late one. It's going to wreak havoc on the trees, but let's see. Working on blood with one of my agencies. It's been kind of an interesting process. Shay and I are. We have a couple of employees who are sort of. One is a city employee, one is a Denver Health employee, but their jobs really relate to the entire system of emergency medical response and Denver Fire, Denver Police, 911 system, and Denver paramedics. And it's there's a lot of history behind why we're there, but it's a kind of an interesting system where we have a data analyst and then somebody who really focuses on system-based quality initiatives. And is really pretty cool because they serve as the link between all the individual agencies. You know, obviously look at data and look at quality, but we've got somebody whose prime job is really looking at systems issues. And we just kind of onboarded somebody who's got a ton of experience in the system. And one of our first projects is really looking at the agitated patient, acute mental health emergencies, and really how we coordinate between all agencies, including law enforcement.
You guys can give us a report. I figure I got to close this up here, by the way.
Yeah.
You guys can give us a report on what you're finding with that. That'd be great. Shay, anything to add to that? I think you were on, I saw as well.
Yeah, no, nothing else. Excited to have our new person on board and taking a look at some of our big quality things that we're trying to work on. So yeah, very interesting. The skydiver thing gives me pause because we have skydivers for all of our home Broncos games that parachute in. So that's an interesting conundrum. So thinking through that, but yeah.
Thank God you guys don't get any wind out there, right?
Never, ever.
So, all right, that's why the airport looks like sales, whatever. So let's move on to John Jew. Anything you need to report out of Portland?
Nothing in Portland besides we're having struggles with our blood deployment. Our fire agencies are dragging their feet right now, but I have to work behind the scenes. The other one would be from an infectious disease point of view. Mexico is reporting the serotype of the 8-year-old girl that died was a D1.1, and that's a serotype that was associated with the Vancouver teen as well as I think the Louisiana death. So in summary, the H5N1 serotype to watch for is the D1.1 serotype, which is very unusual for us in North America.
Okay, we'll keep an eye on it. Keep us posted. Let's talk about that next week. That would be good. Get us a quick update on it. You know, that kind of thing. Really appreciate it. Stein, anything down in Colorado Springs or anything else?
Yeah, no, we've given our first Suboxone doses on our opioid team, and so that's great. Otherwise, nothing of importance.
All right, got it. Thanks. Great to see you. Terry or Roger, anything to report before I shut everybody off, because we should be shutting off now.
No, I'm good. Nothing.
Okay.
Yeah, just
Okay,
unit
got it.
52 and 53 on our 45th patient, first in a week, and our fourth GYN save in that it was a bad placenta previa. So don't underestimate the times where the whole blood program really help. And then the other thing is as we look at metrics on we're creating on our dashboard, the ability to look at time from dispatch to credentialed EMS supervisor giving the blood, because we're trying to meet the physiologic needs of the hemorrhagic shock patient. So if that's something you'd like me to share at Eagle Creek, I'd love to do that.
That sounds great. I was just going to suggest that. So, and just remind me. And I guess I lost Rob Lowe, but anybody else? Because I'm going to shut us off. Anybody else have anything else to add in here? If not, welcome back, my friends. The show that never ends. Good Friday to you, everyone, and hope those who celebrate Easter have a great weekend, and we'll see you on the other side next week. And I don't know if you saw in our brochure or the invitation I sent out was another hotel that says, "Welcome back, my friends, to the show that never ends." So welcome back next week. See you later. And thank you all. This is just, I learned so much every week. It's just fantastic. So thank you all for being here. And it was very rewarding to hear what Dave Obert had said as well, too, that if I'm helping them out in another country without even raising tariffs on them. It was good. I'll see you later. Take care. Bye-bye.